Habibah,
Yes, kejap ya. Doktor Yani, kejap Saya mencari nama kejap. Ah, eh. Okay, alright. Sekejap Okay, done ya.
so try share screen
Boleh?
Alright, Doctor.
Okay. Kalau kita buat ikut Zoom ni tak boleh dapat presenter punya ni
Presenter punya?
apa tu yang kita boleh nampak the next slide apa semua tu.
Boleh Kak Yani kena use your own laptop untuk display setting tu Kak Yani buat yang Kak Yani kena set dekat display setting.
Display setting laptop
Laptop Kak Yani, yes, yes.
Okay, give me some time ya.
Okay, sure.
Okay. Ni kalau I tunjuk ni you nampak apa?
Nampak yang nampak the presentation tu sekali ni. Yes, this one nampak yang
It's
presentation
the
full.
full Mana tak boleh keluar. What do you see now?
I see the presenter view.
Okay. You can see presenter view.
Yes,
Yep,
yes, presenter
correct.
view.
How do I make sure I see presenter view but you guys see the full screen?
Kak Yani kena pergi dekat your display setting. Kejap saya try tengok.
Ini boleh buat di sana ke?
Saya tak boleh buat daripada sini sebabnya dia dekat Kak Yani punya. Sekejap saya try ni. Saya try bagi direction. Ni, sekejap.
Okay, sekarang kau nampak apa?
Still nampak
Presenter view. Yeah.
Kak Yani pergi kat display setting.
Of my laptop.
Yes, your laptop. Kak Yani keluar dulu daripada view tu, daripada slideshow.
Okay.
Sorry. Kak Yani pergi ke slideshow. Lepas tu Kak Yani right click. This one nampak yang ni. Nampak yang...
Because I'm showing the full screen tapi...
Okay, kalau nak tukar, Kak Yani pergi ke right click dekat situ.
Tak boleh. Okay.
Okay, right click. Right click. Lepas tu...
Sekejap.
Right click pergi dekat screen. Sorry, use presenter view.
What do you see now?
Okay, lepas tu pergi dekat atas tu dia ada... I think dekat bawah.
You nampak apa sekarang, Habibah?
Nampak presenter view.
Jeez.
Selalunya boleh sekejap. Ada tak kat atas tu dia ada kotak kat ni?
Kotak cakap?
Sekejap kat atas ni dia ada cuba yang bawah ni apa kat ni yang titik-tiga tu apa? Yang three dot tu apa?
3 dot. I do not have. Okay, 3 dot kat sini.
Di bawah daripada present yang mucositis punya first page tu. Ada 3 dot kat situ. Cuba klik kat situ. Okay. Kat ini tak ada screen. New slideshow. Yang CC tu ataupun yang sebelah dia yang bentuk macam slideshow tu. Yang tu saya caption. Cuba tengok sebelah dia. Sebelah dia tu. Oh, bukan salah tu. Alamak.
Tak apalah, dah buku tak apa.
Okay.
Hentam je lah. Okay.
Okay. Tukar balik ke use slideshow ya. Saya tak.
Cik tulis, "Hai doktor." Alamak.
I tak ada kamera kenapa Hai Tarani.
Hi, Doctor. Okay, are we ready to start?
You do not see my face kan?
I don't. Yeah, is your camera switched on? There it is.
Oh.
Yes.
What's
We
that?
can see you.
Sekejap ya.
Okay.
Okay.
All right. Thank you, everyone, for joining us today. We have with us today Dr. Suryani Sukari. So Dr. Suryani obtained her master's in dental science in pediatric dentistry from Leeds in 2010. She was in Queen Elizabeth Hospital and Sabah Women and Children's Hospital prior to working in Hospital Tunku Azizah KL. She's currently an active member of various training groups involving nitrous oxide and is also a coordinator for quality assurance programs within her department, among others. She boasts a long list of achievements in her CV and had to condense this, but we are so pleased and so honored to have her here today to share with us her knowledge on mucositis. I'm sure a lot of us, we got a lot of requests regarding this topic. So we hope that everyone here today would be happy to listen to it. So over to you, Dr. Suryani.
Okay. Assalamualaikum and salam sejahtera to all listening. Thank you, Tarani, for having me here. Would like to share a little bit of my experience, a little bit of my knowledge.
Can we please, anyone that joins in, just remain muted, yeah? Unless you're the speaker.
Right. Okay, so it's a sharing session. I would welcome anybody who would love to share their experience as well. Okay, so the topic given to me is understanding and managing mucositis. Right. Okay, so this is the outline of my content. Before we proceed, we really need to understand what is mucositis and then how does it look like, what diagnosis, and then share what is there outside in the literature about managing mucositis. And maybe we'll share a little bit of what we do in my department, and we're going to conclude, yeah? Right, so by definition, the term mucositis is inflammation of the mucous membrane of our alimentary tract, the whole gastrointestinal tract. So the correct term for this sharing session would be oral mucositis, which means the membrane lining your mouth, right? The oral and oropharyngeal cavity. Is it very specific? Does oral mucositis belongs to the toxicity of chemotherapy? There will be many sites, many organizations that will define mucositis, which is related to cancer therapy. However, in one of the guidelines by ESMO, it says that oral mucositis also can be termed whenever there's infectious disease, immune deficiency, medications. So it's not limited to cancer therapy. So now comes the question, is it the same as stomatitis, which also means inflammation of your mucous membrane of your mouth, right? Just to make it a bit, just to be clear, generally the term oral mucositis is used mostly in conditions associated with chemotherapeutic agents or ionizing radiation, cancer therapy, and stomatitis is other than that. Except, to make it more confusing, is that there's such things called MIAS. So what is MIAS?
Apa yang doktor
Macam nak share kat korang.
All right. So there's many types of cancer treatment. One of it would be targeted cell therapy. It attacks cancer cells and try to reduce toxicity to normal cells. So one of the agents used in targeted cell therapy would be your mTOR. So mTOR is mammalian target of rapamycin inhibitor. So in targeted cell therapy, some patients might still get mucositis, but they are not termed as mucositis. They will be termed as stomatitis, MIAS, right? So it's a totally different ballgame. There's a different mechanism. The presentation is all different. So therefore, they are given a different term. So for the rest of this sharing session, we're just going to talk about oral mucositis related to cancer therapy and not this at all, okay? We have to talk about Sony's 5 phases of oral mucositis. Okay, right, so there's 5 stages arbitrarily given, these 5 stages. So there's initiation, signaling, amplification, ulceration, and healing. So during the first box on the left is your normal cells. You have intact epithelium, your basal cells is thriving, there's vascular vessels underneath in your submucosa. And then comes in your insult, your radiotherapy, your radiation, attacking your basal cell. Once it's attacked, there will be reactive oxygen species, a free radical that would further cause effect to the cells that is there. So the ROS will upregulate the inflammatory cytokines, leading to further damage, apoptosis, and then causing more damaging events. At this point, the clinical presentation seen in patient's mouth might be normal or slight redness. And the 4th phase is when you have your ulcers. Ulcers mean breakage in your epithelium, therefore exposing your submucosa to attacks by various microorganisms. Okay. At this point, patient will feel very painful, would feel pain, and you can actually get sepsis. And then the 5th phase is when your epithelium heals, there's differentiation, it migrates, it closes up again, the ulceration. So everything is back to normal. You see, it's self-limitation. So when we talk about oral mucositis, there must be 3 things: erythema, edema, ulceration. Okay. However, if we were given this patient, somebody from the onco ward would call us for opinion on what is this. Okay, so you may have a few differential diagnoses. By technical term, it's not wrong to say it's oral mucositis because it is the term oral mucositis by itself is actually inflammation of any your mucous membrane. However, like for A to B, is clearly a traumatic ulcer. You see there's keratinic margin. The ulcers are irregularly shaped. The margins are raised. For C, I'm sure you have seen cases like this in the ward. You can see white striations with ulceration in the middle of it. So this paper has defined it as has diagnosed it as ulcerative lichen planus with multiple shallow ulcers. From D to F, your F's ulcers, it's usually circular. It has a nice erythematous halo around it, right? And then from G to H, vesicular lesion. And of course, everybody in the dental world would know a very deep ulcer with everted margin, rolled up borders. You would think of malignancy straight away. Okay, so these are some of the differential diagnoses. I've had my officers telling me that Doctor, there's a case in the ward referred to us with coated tongue or redness of the tongue, an indentation of the margins of your tongue. Is it mucositis? And to be honest, sometimes I'm not sure myself. Sometimes I have had done dragging or medicine pathologists and pathologists to come and see in cases which I am not sure. Does it make a difference? It does in some cases. So how do we determine then, is it oral mucositis or is it not? So looking at the position, there's some clues to how we can say it is oral mucositis or not. The first one is location. Number two is the timing. How does it look like clinically? Did you do any investigation results and others? Right, so you know your ulcers, your oral mucositis would happen where? It would happen in your non-keratinized surface. Where's your non-keratinized surface of your oral mucosa? Your buccal mucosa, your lip mucosa, lateral and ventral side of your tongue, soft palate and floor of the mouth. They are prone to inflammatory process. They are less tahan to mechanical injury, so they tend to get oral mucositis. Okay, so for timing, if a lesion appears 6 months after the last chemotherapy, you would looking like oral mucositis, you wouldn't put oral mucositis, right? Because it has to happen within duration of time from the insult of the chemotherapy or radiotherapy. So within after 1 week, depending on what kind of chemotherapy, what kind of agent that we're getting, within 1 week, you might see ulcers. Patient would be complaining of clinical symptoms, and then it would peak towards the end of 2nd week, and then healing will happen. So if it correlates nicely with your chemotherapy, it probably is oral mucositis. All right, so again, ulcer borders for oral mucositis is usually poorly defined. You cannot say it's circular. You can't sometimes see where is the margin. There is no erythematous margin. The margins also wouldn't have that keratinic margin, just like that traumatic ulcers. The ulcers is said to be more deeper as compared to aphthous ulcers. So this would probably give you hints. Does patient have neutropenia? Does patient have a test done to see whether he is having hepatic infection or viral fungal infection? And then oral mucositis usually will happen when the ANC is really low, and it starts to resolve in correlation to the picking up of ANC. It's not a causal relationship. It's more, but you can see association. Many
Saya
people,
mute.
maybe some papers would even state that if ulcers are present on the hard palate attached gingiva, you know, your keratinized surface, mucosal surface, culture should be obtained to rule out viral or fungal etiology, which is common because patient is immunosuppressed. Okay, so once you were to see this, symptoms of discomfort and pain would come before any visual tissue changes, right? In the early stages, there might be areas of redness, and then the red area will progress to form ulcers, and the ulcers would be yellowish white. You see the irregular margin? Again, patients will start complaining of feeling irritation, and maybe by then you would see redness. Sometimes the redness will appear without any complaint of pain. But if there is pain, some patients have reported this feeling as burning, a feeling of burning. Then the oral mucositis will progress to erosion and ulceration. Pain will come here because it's the 4th stage of Sonney's 5 stages. And then later, the ulcerations will typically covered by white fibrinous pseudomembrane, and later it would heal. So there's a progression of this. So knowing this, you'll probably be able to differentiate whether the diagnosis. Okay, so the incidence and severity of oral mucositis vary. It depends on a lot of factors. Right. Many papers are quoting, it's quite difficult to quote a number because there's a variation of cancer diagnosis, variation of agents being used. And the thing is, there's no one standard index or scale to show that patient is having what kind of mucositis, right? So mostly you would get a higher chance to get mucositis for head and neck radiotherapy combined with chemotherapy, for patients having stem cell transplantation, any head and neck radiotherapy, and your chemotherapy would be, you'll probably see it or not. As you've seen in our patients, sometimes when we ask them, they have actually gone through the whole of chemotherapy without having any mucositis. That's quite common. So oral mucositis, as we know, is self-limited. But why are we bothered about it? Because it can cause patients very severe discomfort, and there's a decline in quality of health, not just pain. Once the patient, we are treating kids. So once there's pain, patient will refuse to eat. They'll feel very upset and moody. There will be dehydration coming in. All right. So therefore, there will be, the onco team needs to come and help with parenteral nutrition. Once there's a break in the mucosa, you might get infection. And also, if the mucositis is very bad, it would influence the treatment, whether or not to proceed. And this delay and break may lead to a different prognosis. And then from an economical point of view, of course, the hospital and the ministries have to face costs incurred with symptom management, nutritional support. And if there's a secondary infection, it'll be worse still. Right, so we have to talk about skills, right? So there are many instruments that has been developed. You would see the common ones like this: the WHO toxicity scale, the top one is WHO. So this is easy for clinicians like us because it comes with presentation, patient's presentation, and it's really objective. Okay, whereas you would see the other common ones would be NCI. NCI means National Cancer Institute. They have a CTC, CTCAE, which is your criteria for common terminology criteria for adverse events. So this NCI CTCAE is divided into 5 levels. WHO has only 4. RTOG is used for radiotherapy or mucositis. The other ones that we should probably be familiar because it's used everywhere in different studies will be the Oral Assessment Guide and the OMAS. Let's see, this is the CTC, the NCI CTCAE, the adverse events. So it's actually divided into the functional and clinical examination. If you're asking me whether it correlates with each other, some will try and see whether it makes sense or not, not make sense, whether it correlates with each other. This box on the left side shows a CTC of grade 3 is different as compared to WHO. You see how grade 3 for WHO is a patient is able to still eat, although it's liquid diet, whereas for NCI CTC, it's requiring IV hydration. So it's not really the same thing, okay? Down here is your oral assessment guide, and they divide it into 1, no normal, 2, mild to moderate change, and 3 is moderate to severe change. And they will subjectively, they will try and document all this according to these 8 swallowing process, lips, tongue, saliva, mucus. So you see there's quite a few. Right, so now we come to how do we manage mucositis? Lots of people are asking me, is just giving chlorhexidine, is that okay? Just giving D-flam for everything, oral toileting for everything. I'm afraid there's no one easy answer. There's no one strong evidence, a protocol that would fit all patients, okay? It needs an individualized plan of care. And there's many inconsistency. You will see many people doing a lot of things. If you read up case reports, inconsistencies, and very hard for us to compare. All right. And whenever you read oral mucositis researchers, the evidence are very specific. It's either you're talking about prevention of mucositis or you treat the symptoms. What kind of cancer are you talking about? What kind of intervention are you talking about? How much radiotherapy are you giving? Are you giving 50 gray? Are you giving 60 gray? Are you giving 30 gray? It's all different. So therefore, you cannot summarize everything under one box. So let's look at this. For example, whoever asked me whether I can just use chlorhexidine to manage oral mucositis, there is in fact there's many papers that state there is evidence against the use of chlorhexidine for, it doesn't prevent oral mucositis, against chlorhexidine use for prevention of oral mucositis in head and neck cancer, patient who undergoes radiotherapy. So there's a very specific statement regarding chlorhexidine. However, it does not exclude other indication of chlorhexidine, such as prevention and treatment of oral infections, such as plaque-induced gingivitis, such as poor oral hygiene, unable to brush for 5 days. So they do not prevent us from dentists from using chlorhexidine, but you must understand what is the chlorhexidine used for. Okay, it does not help to prevent oral mucositis. Right, let's see a paper, the example. So a systematic review for using anti-inflammatory mouthwashes to manage oral mucositis. So you see again, after the whole thing, the statement it comes up with, there is sufficient evidence to recommend the use of benzidamine, your best friend, the Difflam, for the prevention of oral mucositis in patients having head and neck cancer, receiving radiation therapy up to 50 without concomitant chemotherapy. You see how specific it is. Okay, so this is evidence, I think it's level 2. So, and just when we are working in the real world, when sometimes we say, okay, I heard there's a level 2 evidence using Difflam in cancer patients, and then everybody starts using Difflam for every cancer. Okay, so the evidence is just for this specific head and neck cancer patient receiving radiation therapy 50 degree without any other chemotherapy. So, so you see how specific it is. All right. Then there is also against the use of misoprostol, is another anti-inflammatory mouthwash for prevention of oral mucositis. Okay, again, Cafesol. Everybody should know what is Cafesol. It's a mouthwash containing calcium and phosphate, supposedly to help oral mucositis. Papers aren't great, but Cafesol are being mentioned in a lot of mucositis guidelines. Cafesol is also very expensive. It's like 1,000 ringgit for a box, which will only last 1 or 2 weeks. Okay. So now we're going to go into guidelines. I know it's pretty boring, but when we talk about guidelines, then I'm going to pick up and point out some of the things that I find interesting about every guidelines. There are many guidelines available. If we are going into, guidelines that say dental management of patients undergoing chemo-oncology treatment, there might be a small segment on oral mucositis in that, such as the Royal College 2018. There's a small segment talking about mucositis, and it doesn't contradict, but it's very summarized, right? So there are papers, guidelines talking about dental management for patients undergoing onco treatment, and there are guidelines talking just on mucositis. And these associations managing mucositis are actually a big professional group with a lot of professional people. All right. There's some disclaimers before we go on to the guidelines. We need to be alert on the changes. Some, like the MASCC, they change quite often. So we need to update ourselves. There are changes, and they will always blast, the new information after every new guidelines is being produced. For example, in the MASCC 2014, they suggest against misoprostol mouthwash based on that paper, and then it was reversed to no guideline possible in the latest MASCC 2020. And for instance, the field of laser and light therapy. So this is called the photobiomodulation. They are now being termed as photobiomodulation. It's low light laser. So now there's a lot of good evidence. I think it's a level 2. All right. So it's so they are using intraoral photobiomodulation for head and neck patients receiving radiotherapy, and from being suggested in 2014 guideline is now recommended in the 2020 guideline. And again, very limited guidance on pediatric patients. So we take everything with a pinch of salt. And then again, when we read guidelines, look at the level of evidence, right? So there's level 1, 2, 3, 4, and 5. Apparently the levels for a lot of 2 would be very, very rare. Difflam would be one of the level 2. Your basic oral care would be level 3. And then whenever we read guidelines, you look whether it's recommended in favor or suggestion, recommendation against, and suggestion against. You know, it's all very specific. Let's look at MASCC. So they have produced, they are one of the main ones. They started in 1990. In 1998, they combined with ISO, and they produce really good guidelines, and they do regularly. Okay, they even produce papers just talking about basic oral care, the BOC. So for the latest one, which is 2020, there are some changes. They will even produce presentations for easy discussion for those who only want to read the updated version. For those who want to read the full version, you have to go back to 2000, the ones before, and then slowly see the changes. So they have this for 2020, they talk about blend oral rinses. Blend oral rinses is there's actually no evidence, no strong evidence. But then the MASCC says, as an expert, they made a consensus that although data is limited for all the types of blend oral rinses, the panel recognizes that these rinses are will increase oral clearance, which may be helpful for maintaining oral hygiene and improving patient comfort. So it doesn't help with mucositis, but it helps with the oral clearance, which may indirectly help in some way. So they would mention if the guideline says it's just NGP or / expert opinion, they would clearly put it down. And then for chlorhexidine, again for 2020, the panel suggests that chlorhexidine not to be used in the prevention of oral mucositis in patients undergoing, again, I'm going to repeat it again and again. But then there was no guideline possible regarding the use of chlorhexidine for treatment. You see, this is treatment. Previously is prevention. So that they cannot produce any statement regarding the use for treatment of oral mucositis in all cancer population due to conflicting or limited data. Right? These are just two examples. There are many, many things. It's impossible for me to actually go through one by one. Okay. So MASCC actually produced this a simple summarized version. Every time a new guideline comes out, they have a summarized, which we can actually print out and leave it, put it out for easy reference. ESMO is another has produced a guideline as well. ESMO represents European Society for Medical Oncology, and I really like ESMO because the website is give us easy access to the guideline, and there's an interactive version. Okay, so but then the weakness is that I think the latest one is only 2015. The one before that was 2011, right? So I like their guideline because it's color coded according to the level of evidence. You know, if you're really into going to the level of evidence before trying anything on, right? Right. So JNCCN, okay, is National Comprehensive Cancer Networks. So it's 27 cancer centers in the US. They also come together and to produce a guideline talking about prevention and management of mucositis in cancer care. Right, so I like this part of their guideline. They divide it into a stepwise management. So once a patient has mucositis, they divide it. They would say, is there xerostomia accompanying it, or is it just pain? So if it's pain and it's mild pain, they propose blend oral rinses, right? And then if it doesn't help, or if the pain is moderate, then you go into other intervention. So they actually propose blend oral rinses, right? In their stepwise pathway, they also talk about infection. Either you can do prophylaxis. This, like most of our patients are already on nystatin. They prophylax, and then treatment is proposed here. And of course, if there's xerostomia in radiation to the head and neck patient, then of course they would try a lot of other things. Okay, UKOMIC is United Kingdom Oral Mucositis in Cancer Group. So there's a huge group consisting of everybody. I'm not sure whether this one has dentists or not. So they produced guidelines 2012, 2015, 2019. They emphasize on improving mouth care, right? And it has to be individualized plan of care, timely preventive measure. And in their guideline, they want us to manage according to the risk of oral damage. And then let's see an example. So they also have a summarized attachment, appendix for management for us to easy referral, but it's of course not as thorough as the MASCC. EOCC, the European Oral Cancer Group, also has a guideline, and it's also easy access. Right, I like this BC Cancer, British Columbia Cancer Group. So they produce a guideline, and they even give us an example of an assessment form. So whenever we want to manage oral mucositis, we should be assessing it, properly, have a pro forma, what needs to be there in our assessment. So it's quite they have actually put down easily the things to ask your patients, what is the severity of your oral mucositis, what are the presentations, what have patients tried, and then is there a change in your taste, is there difficulty in speech. It's very, very thorough. Okay, so the assessment form is given in this BC Cancer Group. Right. Remember, if you we were talking about scales, so they are using NCI CTC, the National Cancer Institute, common toxicity criteria of the adverse effect of cancer. It's very mouthful. But anyway, they are using grade 1, 2, 3, 4. So according to this scale, they have proposed a management. So if a patient has a grade 1 NCI CTCAE, this is how they would manage. You would always do assessment, pick up on the oral hygiene, improve oral hygiene first, just like MASCC. They want the basic oral care to be, at improved first. It has to be at a baseline, right? And then they would give all this in nice boxes. For instance, radiation therapy. So they would propose benzodiazepine. Again, clostridium not recommended here. Oral therapy is proposed. Patients sometimes can hold ice chips for the 5 minutes prior or during. So all this, you see, this very nicely summarized, right? And then they talk about magic mouthwash here. All right, so then they go on to grade 2, grade 3. Again, you see, they even include dietary management and what do you need to do, how often you need to see these patients. And then again, you go to grade 2, CTC, NCI, CTCAE. And this is what they would propose for grade 2 and grade 3. For CTCAE, grade 2 and 3 would be patients not able to tolerate adequate daily fluid intake. This is what they would do. And then okay, and then brushing, flossing, dietary. Whenever patient have difficulty eating, you change the food texture. You need to include more fluidy, more liquids. And then whatever you have oral complications such as pain, they would propose all this. How much of oral rinses you need to do, how many times, lip care, what do you need to do for dry lips? Is it important dry lips? Most guidelines would say do not use petrolatum-based medicament to prevent dryness of the lip. Use the lanolin-based or water-based. And then again for grade 4, grade 5 is death. Grade 4 is the worst part of it. So these are what they would propose. So again, all guidelines would talk about basic oral care, right? Not just MASCC, but because MASCC would be easy for us to refer to because they produce a specific BOC guidelines, okay? How it helps is by reducing microbial burden, therefore it may avoid secondary infections. So I'm just sharing what our department has, right? So we the principle of in our protocol, our departmental protocol, we put in basic oral care. So inspection, you need to do the basic, the common sense, eliminate sources of trauma, eliminate sources of infection, your caries. Of course, depending on other guidelines, if it needs to be invasive, patient has started radiotherapy, chemotherapy, then sometimes you need to consider other things as well. But these are some of the examples. Basic oral care according to MACC level of evidence. And then when we, again, now we go into management of mucositis. So either is prevention or is treatment. Once you talk about prevention, MASCC would talk about all cancer, what kind of agent, what kinds of therapy they would suggest for this kind of patient, for BMT patient, for stem cell patient. And this is MASCC level 2 for use of cryotherapy, level 2 for low level laser therapy, the photobiomodulation. So they put it there. So the strength of the evidence is level 2. And there's a level 1 against, okay, now reverse to NGP. So then they go to prevention of mucositis in head and neck cancer patients. So comes in your benzidamine level 1, sorry, so it's a level 1. For those receiving head and neck and chemotherapy together, then it's a level 2. And then, so all these are evidence for head and neck cancer. The ones that I've slashed would be after after they proposed the 2020 guideline. Again, prevention of mucositis. The first box was all cancer, and this is head and neck cancer, and now this is your hematomalignancy. So they were talking about palifermin, cryotherapy, and then the rest would go under others. So then it comes to the treatment of mucositis. All this was suggested for all cancer and head and neck cancer. There is a level 3 suggestion use of 0.2 morphine mouthwash. That's why you would see all this, because MASCC has said that it's a level 3 and the usage may be effective to treat the pain from mucositis in head and neck cancer patient. Again, the sarcophagus comes against, but it's NGP. Okay. So this is to make it easy for you to remember, okay? This would be how we treat our patients, because in other than just having pain and ulcers, they would also come with other things. So for pain, we prepared a protocol for officers to manage. I like, for instance, cold therapy, what kind of topical agents that we use. Most of us would have Deflam. But as you know, Deflam in Malaysia is only proposed for patients above 6 years old. In UK, Deflam is used for patients above 12 years old. Sometimes if patient comes at 4 years old, would you give Deflam? Sometimes I had to, because there's no other things that can be used. You know, it depends. Guidelines are to guide you, but you take into consideration other things as well. Okay, so all these Genji gel, Aftermath, those are actually called coating agents. They apply a coating of protectant. Okay, so patient will feel less pain. There's also systemic agents to help with pain. Sometimes we see patients coming in just with paracetamol, but once it gets really bad, then it's just morphine. I've even seen paracetamol mouthwash in one of these papers, but I do not have time to read about it. But depending on the severity of pain, then morphine usually would be, if it's nothing else works. All right, so sometimes patient might come with xerostomia, which will worsen your mucositis. It is not a criteria for mucositis, but if you do have it, it's going to worsen your pain. So there are things that we propose for xerostomia. Adequate fluid intake. But you know, kids, you ask the mother, please ask your child to keep drinking, keep rinsing. Of course, the child will not. He's so upset. He's so, he just wants to relax and sleep and cry. So they will not drink water. So how do we make sure adequate fluid intake? How do we do that? It's a problem, right, for patients that we face. We need to lubricate the oral mucosa if it's really dry. You know, we have the oral 7, we have Cefasol, constantly sipping water. I actually use saline spray. Ask the mother to put water in your spray and upper spray on the mucosa to keep it nice and moist. Sucking crushed ice is also proposed in guidelines. Again, blend oral rinses. There are sometimes saliva stimulants being proposed depending on a lot of things. Saliva substitute and to lubricate the lips. Once the lip gets dry and the patient picks the scabs off your lip, and it's just going to worsen everything, all right? So you may think it's something simple, but lubricating the lip does help your patient. Do not ask your patients to put Vaseline on top of a dry scab. It doesn't do anything. Vaseline actually just keeps the moisture. So if there's no moisture underneath, it's dry scab, it doesn't do anything, right? Again, water-soluble lubricants, lanolin based lubricants are proposed rather than petrolatum lubricants. And then we also want to prevent opportunistic infection. We ask patients to keep their mouth clean. There are some oral medicine pathology would always tell me, please sodium bicarb in the morning. It helps to clean all the thickened mucus saliva in the morning, and then helps to wash the mouth. A lot of rinsing will help. Okay, if patient cannot brush, then comes in your sponges, your mouth rinsing, your chlorhexidine, maybe in bigger children, your Difflam Win and Difflam C, because it helps with the pain, and the chlorhexidine in the Difflam C would also help to prevent opportunistic infection. But if the oral hygiene is really good, there's no caries, the gingiva is healthy, patient is still brushing and flossing, I do not see any reason to add chlorhexidine to the already so a long list of management by these patients. So in our protocol, there's of course step 1 is your basic oral care, your assessment. Number 2 is your basic oral care. And then we manage patients according to WHO grade 1. We use WHO, all right? So once WHO grade 1 means there is erythema, there's soreness, but there's no ulcers yet. So what we do is that apply basic oral care protocol. Hydration is important. How do you hydrate your mucosa? And then, is there any changes in your dietary management, right? So if patient is okay, there's no pain, just continue whatever they're doing. Of course, we encourage more fluid intake. If there's pain, we use this stepwise approach by ESMO. Okay, so this is grade 3 and 4. There's severe ulcers now, there's severe pain, but patient is still able to take orally. So we still go back to the oral hygiene, basic oral care to ensure it's at basics, lubrication, hydration, dietary management. Now, of course, it will be okay, sorry, grade 2 is when you need to change your food texture, because if there's now pain, there's dryness, you need to make sure the food is of a liquid type. And in grade 3 and 4, parenteral will probably be better. We're talking about dietary management. And then pain management, most of the time now it comes in with more guns, you know, all the coating agents that we use, we just try whatever. And then if there's bleeding, you can use your tranexamic acid mouth rinse. And then again, look out for opportunistic infection. So you see, after we went through all that, there is no one magic answer to treating oral mucositis. Okay, so it is a severely debilitating condition. You need to have erythema, edema, ulceration for you to be able to say, and remember the clues about how to differentiate it from anything, the other differential diagnosis. There are guidelines available. They are quite good because they are regularly updated. Of course, not much around for pediatric patients. If you were to read papers, they are very, very specific. And in the end, you have to go and read out your systematic review, and if there's any corporate review, to just gather enough information from this very, very specific researchers to treat for the baseline of good oral mucositis management is that I would propose, like us, we have a protocol to ensure standardized provision of management, have a nice index so that everybody knows that the mucositis is improving or not. Okay, and the care should be individualized to what patient need. Is patient able to rinse? Is patient able to tolerate stingy chlorhexidine? If they can't, maybe blend or rinses is better. Use of Difflam or Difflam C depends on if there's a need to it, right? So everything is to be according to patient's need, individual need. Documentation is good. You see how a lot of guidelines, they propose good assessment, right? This performance being proposed. Then of course you need to use a validated oral mucositis scale index. Basic oral care is important. Cannot say emphasize more than that. And then I know most of the time we are doing a lot of symptomatic treatment and palliative care. So that's it from me. Would appreciate if anybody would like to share their own protocol that they have and they use successfully. Let's stop sharing.
Thank you so much, Dr. Suryani. You have really taken the time to go through so many guidelines and condensed it so that, we will all get educated on mucositis. I really appreciated that aspect. May I please, can I ask a bit more about the magic mouthwash? What is it actually?
All right. So magic mouthwash is, as you remember, the mucositis consists of a lot of inflammatory things are happening, right? So a lot of cancer centers, they propose their own mixture of mouthwash. And every single center would propose and show their success rate. But how we cannot take this to be used because none of it is the same. It's either it will contain either morphine for pain control, we'll have some anti-inflammatory in there, there will be some maybe some people propose sodium bicarb. So yes, it is around. My previous boss, Dr. Ganesh, loves it. He has a special recipe, but depends if your pharmacist can actually produce it because it needs to be prepared fresh. So you can go to your pharmacist, have a recipe that you like from a certain center, get your pharmacy to prepare and see. Why not? Why don't you guys do a study? But yeah, I see a lot of this, and a lot of people would always ask me about this magic mouthwash, but I cannot come up with a nice standardized recipe for it. There's so many types.
Dr. Suryani,
Yeah.
Habibah here. I just want to ask question. Is that okay, Dr. Tarani?
Of course, sure. Anyone who wants to
Okay.
ask any question, just unmute and
Okay,
shoot.
all right. So my question is that previously they asked for things like mucositis. They asked us to do oral toileting for patients who are in pain. So what is your suggestion whether to clean using something to open the wound and put the gel or anything like that on the wound, or we just give painkiller and patient do it on their own, the oral toileting?
Right. So toileting means you're debriding. I would say oral toileting is best if you can keep to your basic oral care, which is your brushing. Your brush would be more better than using a sponge, right? So your brush would go into your embrasures. You can clean all the food. If patients can bear with the toothpaste minty taste, then go ahead. If not, some protocol would say just no toothpaste. But of course, fluoride is important for us. Okay, so if patient is unable to brush, he is in so much pain for 3-4 days, nothing can be done, then for us, we will usually come and bring our sponges. So the sponges comes on a stick. There are some that contains sodium bicarb, there are some that contains fluoride. So there are many kinds of sticks. So it helps for us to do a bit of toileting without causing so much of pain. It doesn't scare the patient so much. And then sometimes it contains really nice flavor, blackcurrant flavor. So what we want from patients, usually those having severe oral mucositis usually don't eat anyway. So we wouldn't worry so much of having food in between tea. They probably is not eating for a few days, but we want some flushing going on, or rinsing. You do not want stagnant mucosa in the mouth being so stringy, containing lots of bacteria. So of course, the ideal to answer your question would be ideal brushing, and then of course later you compromise. You doing it will be more scary to the patient. Maybe you can ask mother and give specific instruction to mother. The thing is, sometimes when we have more agents to help with mucositis, we give the whole list to parents and they get confused. In the end, they don't do anything. So try custom make to see the parent's mother, patient's mother, whether they can cope with so many things. If not, write it down. Your main aim would be keeping the mouth clean. And then later you want to keep the mouth hydrate. And then if the mouth is dry, you want to give oral 7 to hydrate the mouth, stuff like that. So the best would still be brushing if you ask me.
And one more is that I think I'm here in Kota Baru. We don't have many patients with oral mucositis as you have in HKL. So I just want to know. I just missed halfway of the presentation because I have patients just now. So do you mind to share your protocol or your forms to us so that we can maybe use it as a reference in the
Yes,
future?
I think that's but then you, like I say, take it with a pinch of salt lah. I have tried to update it as best as possible. We started it off with Dr. Jane and Dr. Ganesh together, and then over time we added onto it. So it's supposed to be used, but then you have to review it every so often. So yes, I'm happy to share if anybody wants it. No problem.
Thank you.
But the guidelines outside are actually quite good. Not that I'm not willing to share, but they're actually quite good. If you just pick up one guideline out of the many that I've mentioned, I think that's still okay.
Thank you, Dr. Surani, for the input.
Thank you so much, Doctor, for taking the time to answer. Can I further ask more questions about the magic mouthwash? Because some people have messaged me. They want to know, what does HTA use specifically in terms of that magic mouthwash?
The thing about magic mouthwash is that you need to ask your pharmacist to prepare it for you. So the last time, I think when Dr. Ganesh was still around, there was this pharmacist who was willing to do it for us. But now they don't. And since they will also question, because there's so many types of, we do have so many mouthwash now. We buy Aftermath Infants, we have Genji Gel, we have Mucoclair, you have, there's quite a lot. So sometimes they query whether you're still wanting this. So I haven't used magic mouthwash since Dr. Ganesh left. So I'm not sure how easy is it for you to actually ask your pharmacist to mix it fresh for weekly use.
The ingredients inside the magic mouthwash, is it very specific, or is it like grade A drugs like morphine or something that's very difficult to procure? Or
there are some with using morphine and some steroids, depending on what. I might still have a few of the recipes from before. So anybody who wants to look at it and with the reference, drop me a line. I definitely have it somewhere. So you can see and go to your pharmacist and see, are they comfortable to actually do it for you? And maybe do a study. And another thing which is really good nowadays is the photobiomodulation. There's so much of evidence in adult. So if we want to do, well, I know the machine has to be around, but it has to start somewhere by, maybe just at least by somebody who wanting to do research on this low level, because this LLT is everywhere for your acne, for your hair loss. People are selling it on Lazada. So there is intraoral photobiomodulation that probably we should look into, since the evidence is really good for adults.
okay, Doctor. Okay, thank you so much for elaborating. Does anyone else have any further questions for Dr. Surani? Because she's she knows everything. She knows a lot of stuff on mucositis. So please shoot her some questions, because it is as what she said earlier. A lot of us are very used to okay, if you have mucositis, you'll start them on Tiflam or chlorhexidine, which if you look at the guidelines, it's not really advised to do so. And then most you would just give them Genji Gel to cope with to manage it and to cope with the pain. So anyone who has any questions, now would be a good time to ask Dr. Surani. Since being in HTA, she does see a lot of on-call patients as compared to the rest of us.
May I
May
ask,
I say something
Habibah?
about the chlorhexidine? It's not suggested to be used. It's just evidence against the use of it in certain group of people. You can still use it if there's plaque-induced gingivitis. You can still use it if patient is not brushing, as long as we are aware clearly what is for. What was the other thing that you commented?
Dr. Suryani,
Yeah.
may I ask one more question? If you compare by using, because actually the company, the Oral 7 keep mentioning that their Oral 7 is using enzyme, which is better than the chemical, the chemical components. So what do you think? Using to compare the use of Aftermat, ginger gel, and Oral 7, is there any significant in terms of the healing?
Well, very difficult for me to say. Sometimes our patients are so in so much pain that in the end we just give everything that we have, right? And then Oral 7 we just we just recently got it. So it says it promotes hydration, and hydration helps with the pain in mucositis. It helps the turgorness of the turgor of your mucosa. So it helps the mucositis in a different way as compared to your coating agents. Coating agents just cover the raw area of your ulcer so that patient doesn't feel so much pain and he's able to eat. So it's a different kind of pathway. Do not have the answer to that. Sometimes we just give whatever patient is happy. If mom says, the Difflam is not so nice, then we give Dengidel. Patient Dengidel also not so nice, then we give Aftermat. Sometimes just try and error. After going through all this evidence, but in the end, for our patients, sometimes we just do whatever we can. We are just like so desperate for some outcome, right? So in the end, it's probably Difflam also for most of our patients.
Correct. Thank you, Dr. Suryani.
Thank you
Dr.
so
Suryani.
much, Doctor.
Sorry, Wafa here.
Yes, go ahead. I'm just going to close to charge my
All right.
laptop.
Okay, Dr. Suryani, I want to ask your opinion about the use of laser in treating mucositis. Have you ever tried or would you recommend that?
Right. As I mentioned, there is a lot of good evidence in adult using low laser. They even in MASCC guidelines, you would see they have I'm not sure whether I have it here, but they put the specific details for if you want to do this kind of study. Let me just see. Last time there was a university professor who proposed to do a study on low laser light. We do not have it yet, so we are welcoming anybody with a proposal to do this. The machine and the asset will of course be a major thing, but I think it's a great idea. It's a great idea. Yes, it's here. So you go to the summary of MASCC 2020, they gave a wavelength that would be great for what's the duration like, what's the frequency like. So anybody wants to start off with a research, is there. Just start off your research. I'm willing to start, but of course we don't have the machine yet. What about you, Wafa? Do you have the machine accessible to you?
I don't have one, but you need justification to get one machine. So of course that why you want to purchase the machine, then you're gonna justify then make sure that you use in a lot of cases. So in PITS sometimes it's quite limited. So that's why I nak tanya about the mucositis. I haven't tried one, but usually they use a lot in adult and they have good results. So I'm not sure if anyone have used in PITS and what are their opinions, whether it's painful, sometimes it's about the pain and also the complications of the child.
I'm sure everybody thinks about how this study would be great to be done in children. We just replicate somebody's methodology, but then to get a child to open their mouth for you to put the intraoral probe to do that laser, I'm not sure how successful you're going to be. But maybe we could do a case selection of a bigger child, who would listen to us and do. I think it's an amazing idea.
Yep. Thank you.
Thank you, Wafa. There's a question in the chat box, a last question. What kind of lanolin-based lip balm do you use or do you recommend, Doctor? Actually, we don't have a lanolin, but we use KY jelly.
if I Google lanolin, I haven't seen those in Malaysia. I don't know whether it's available. I just mentioned it out of guidelines, but water-based would be your KY. Even if I want to use petrolatum kind of lubricants, I would always tell parents to moisten the scabs, not too wet, get it a little bit moist, and then put your Vaseline on top. It will contain the moisture, and then it will moisturize this scab, and then it protects the ulcers. And once the ulcer is healed, the scab will just come off. Just don't put too much and don't put it on dry scabs. That's what I would propose. But because Vaseline is the easiest one, is the most accessible for us, right? And KY jelly.
Correct. Thank you so much, Doctor, for your input today. Those of you who are interested to get more information about the mouthwash or anything like that, please do contact Dr. Suryani directly via email or via her number if you have it. Thank you so much, everyone. Please use the link in the chat box to sign in the attendance. Thank you, Dr. Suryani, so much for doing this today. I know it was very difficult to coordinate the timings and all. You're so busy. We are all so busy. So thank you for spending the time today.
Thank you for
to
having
be
me.
with us.
Thank you for
Thank you,
having me.
everyone. I will send you the link for the attendance later, Doctor. In case I'm sure you didn't have time to sign in. I'll just send it to you
Now.
later.
Okay, thank you,
Thank you so
Kazim.
much. Thank you.